Hi everyone, I'm Dr. Lim. I'm a radiologist from the Second Affiliated Hospital of Sciental University Medical College, China. Welcome to the online medical imaging class. In this session, we will talk about diagnostic imaging of primary lung cancer. Primary lung cancer is the leading fetal neoplasm in men and women worldwide. Histologically, it can be divided into squamous carcinoma, undifferentiated carcinoma, adenocarcinoma, and alveolar cell carcinoma. Based on location, primary lung cancer can be classified into central type, peripheral type, and diffuse type. The clinical features are variable, correlated with histological type, site, and degree of development of the carcinoma. In this session, we will talk about the imaging features of primary lung cancer based on the site. Central types of lung cancer are most squamous and rapid growing, arising from a main bronchus close to the hilum. Endobronchial lesions produce varying degrees of bronchial obstruction, which can lead to obstructive pneumonia or atelectasis. The direct signs for central lung cancer include hilum mass and abnormality of bronchi. CT scan can demonstrate unilateral hilar enlargement and increased density, tumor mass, and lymph nodes. The abnormalities of bronchi include intraluminal nodule, wall thickening, irregular narrowing, or completely obstruction. Indirect signs of airway obstruction include emphysema, atelectasis, and pneumonia. Here, I will now introduce the sign of obstructive atelectasis, which is very common for central lung cancer. What is atelectasis? It is a loss of volume in part or all of the lung, leading to increased density on X-ray. Obstructive atelectasis is a result of blockage of an airway, usually caused by tumor, foreign body, or mucus plaque. The air in the affected unventilated region is absorbed, leading to collapse. Chest X-ray is generally sufficient to diagnosis. Chest X-ray findings of atelectasis include increased density of the affected lung, displacement of the fissures, trachea, or the mediastinum towards the affected atelectasis, crowding of the ribs, the vessels, and bronchial tree in the area of volume loss, elevation of the hemidiaphragm, and compensatory hyperinflation of the adjacent lobes. This is a PHS X-ray. A fan-shaped area of increased density is seen in the right upper lobe. The horizontal fissure is displaced outward. The trachea is shifted to the right. Here is an important transverse sign, resulting from a central obstructive mass. How do we interpret this sign? The horizontal fissure is attached near the hilum. The right upper lobe collapse results in a fan-like outward movement of the fissure. The upper curve of the S is from the displaced horizontal fissure, while the lower curve results from the mass itself. This sign is commonly seen in central lung cancer, but is neither sensitive nor specific. The chest radiograph on the left again shows a typical transverse S sign and right tracheal deviation. Axial and coronal CT images on the right shows a hilar mass completely occluding the right upper lobe bronchus. Let's have a look at these two axial planes of the chest CT. Wall thickening and lumen narrowing due to a hilar mass in right main bronchus can be visualized. This often leads to atelectasis with increased retention of secretions, which we call pulmonary infiltrations. This is another case of the left hilar mass. Axial medial sinus window of the chest CT after contrast injection shows a tumor mass sitting in and completely occluding the left main bronchus, causing left upper lobe collapse. Let me sum up the diagnostic key point to central lung cancer. There are hilar mass, is the lateral lung collapse or obstructive pneumonia, and bronchial encroachment, bronchial mucus plaque and tuberculosis are the main differential diagnoses. Accurate diagnosis depends on needle lung biopsy or biopsy via bronchoscopy. Peripheral types of lung cancers are most often adenocarcinoma. They occur in subsegmental bronchi, localized peripherally, and are showing glowing. The majority of peripheral lung cancers are peripheral or oval in shape and have irregular and spiculated margins. And last session, we learned about the differential diagnosis of benign and malignant solitary pulmonary nodules. Can you still recall the key points? Yes, we can assess the nodule from the size, calcification, growth, shape, margin, bronchogram sign, density, and contrast enhancement, right? And these two graphs here, I think, help to understand the imaging manifestations of peripheral lung cancer. It can be of any size, but if it is larger than 4 cm in diameter, the possibility of malignancy is high. The neoplasm is most irregular in shape, with visible lobulity and node configuration. The border can be ill-defined, spiculated, and convergence of bronchovascular structures can be seen. The density can be homogeneous. Calcification is rare. Necrosis and bronchogram can be visible. Around the mass, pleural injury sign can be observed. What is pleural injury sign? It is a tear appearing as a line shadow between a mass and the pleural. This is a spiculated mass in the right upper lobe. The lobulated condyle, irregular margin, and pleural injury sign point towards a malignant process. A percutaneous biopsy revealed an adenocarcinoma of the lung. The case on the left shows the signs of bronchogram. The middle one shows bronchovascular convergence. Squamous cell carcinoma is the most likely cell type to show cavitation, presented with a thin wall cavity with irregular inner wall. The process of central lucency formation is due to removal of necrotic tumor content through the bronchus. To sum up its diagnostic key point, peripheral lung carcinoma mainly appear as a mass with lobulated shape, spiculation, pleural indentation, and bronchovascular convergence. They need to be differentiated from inflammatory pseudotumor, pulmonary hematoma, and tuberculoma. Definitive diagnosis depends on lung biopsy. This is a diffuse type of lung cancer. There are diffuse nodules of different sizes in both lungs. Metastasis and medullary TB can have similar imaging findings. And clinical picture is very important for differential diagnosis. Finally, I will briefly introduce cystic primary lung cancer. It arises from the wall of a pre-existing pulmonary cyst airspace, has been reported, but remains relatively uncommon. It is still unclear whether this cystic space were congenital or acquired, and whether the cyst was there before the lung cancer. A cystic nodule may be esophageal and endophageal solid component adjacent to the cystic airspace, irregular partial or circumferential wall thickening, complex appearance with a solid compartment and multilobular airspace. Lung cancer can have a wide spectrum of morphologies, some of which are not commonly known. The basic imaging signs of central lung cancer are collapse of the lung beyond the tumor and the presence of hilar enlargement, which may be seen alone or together. And typical nodules with delobulation signs, speculation, bronchogram, pleural indication, and vessel convergence are most valuable in the diagnosis of malignancy. Unfortunately, all these features can be seen with benign disease. Therefore, previous imaging, clinical information, and lab values, as well as past medical history, are often necessary to differentiate a suspected primary lung cancer from other etiology. And here are take-home messages. 1. Describe the transverse as sign on chest X-ray. 2. Identify the typical radiographic features of central, peripheral, and cystic types of primary lung cancer. And that's all for this session. Thank you for your attention.